Right, good afternoon, everybody. We should probably get started. I'm Jackie Kleiss. I'm co-chair of the hip fracture registry, and this is our annual update for users of the registry, just in terms of changes that are being made going forward. And I guess there's a few this year with the updated clinical care standard as well. Next slide, Sarah, please. So for the Australians amongst us, in the spirit of reconciliation, the Hip Fracture Registry acknowledges the traditional owners of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I'll hand over for Sarah to do her equivalent for New Zealand, the karakia.
Ko Sarah Haring toku ingoa, ko otatai aho. Hello, I'm Sarah Haring. I'm the clinical lead in New Zealand, and I'm just going to start with a karakia. Whakataka taho ki te uru, whakataka taho ki te tonga, kia makina kina ki uta, kia matara ki tai, e hi aki ana te atakura, he tio, he huka, he hohu, tihe mori ora.
Thanks, Sarah. So before we get started, just a few housekeeping notices. So the session is actually being recorded. We know that this time doesn't work for everybody, so there will be certainly people who want to look at this recording at a later date. So it'll be uploaded to YouTube via the ANZHFR website. In terms of questions, so we built in quite a bit of time for questions. We've had a few questions already sent to us as well, which Jamie is going to be typing into the Q&A section. Can you please, if you have questions, use the Q&A function? The chat function is disabled. So just use the Q&A and we'll try and get through as many questions as we can. If we are not able to get through all the questions, we will answer them at a later date. And needless to say, if there's more information that you need after the session, you could always contact Nicola in New Zealand and Jamie in Australia. And on that note, you can see the outline for the session. So we're going for an hour and a half. Not everybody may wish to stay for the whole hour and a half. The last 30 minutes is very much about the updated data forms, so some may not feel that's necessarily relevant for them. But Sarah's going to talk us through the changes that we've made to the data set. Stuart will update us in terms of the registry database. We will have 25 minutes for questions with a panel. Then Nicola will take us through the 2024 forms for those of you involved in data collection and putting in the data to the registry. And again, time for questions. So I think on that note, Sarah, I will hand over to you.
All right. Okay, so today I'm just going to talk about the hip fracture clinical care standard. So this was developed by the Australian Commission of Health, Safety and Quality in collaboration with the New Zealand Health Quality Safety Commission. And the Australian Commission actually have a number of clinical care standards, of which hip fracture is one. And these standards are really set up to help support evidence-based care. So the hip fracture standard has 7 quality statements, and they cover the pathway from when a patient first presents with a hip fracture to when they transition out of hospital. So these were originally released in 2016 and have been updated and revised. And those of you who were present at the Binational Hip Fest in September were present for the release of this standard. So there have been a number of changes which have been certainly informed by data that we have in the hip fracture registry in terms of where there are variations. And they, as well as playing an important part for providing good patient care, they are also looked at when hospitals are being accredited. And certainly if a hospital meets these, then they're more likely to meet the requirements of those standards. So that's important to bear in mind. So if you remember one slide, this is probably it, because this is a summary of the key changes to the standards. So I guess the most talked about one is the reduction in time to surgery from 48 hours to 36 hours. And I know there'll be some people who want to discuss that a bit further later. There's a focus very much on multidisciplinary care, which is a key factor of hip fracture care, and focusing on malnutrition, frailty, and delirium. Pain management has moved to a greater focus on nerve blocks. And with the involvement of HQSC in New Zealand, there's a cultural components with each of these standards. And you can see there the comment from Mātua Doug, Hei waka eke noa. So we're on this canoe together. So it's very much a collaboration for developing these. So I'm now going to take you through each clinical statement and outline the changes. There are some additions, as you've seen, and also a number have been retired. So particularly most of the facility level questions have been retired. So care at presentation. We no longer recording local arrangements in the emergency department. The key difference here is that we are looking at, as well as assessing cognitive impairment on presentation, we are now looking to add in the addition of preoperative delirium assessment. Now, these changes have been put in place to align with the delirium clinical care standard. So what it means is that we will continue to document whether the patient is known to have dementia or not. So their pre-admission cognitive status. What is their preoperative cognitive assessment when they first present? And adding into that, whether the patient has delirium present preoperatively. So recognizing that there's a difference between dementia or cognitive impairment and delirium. And again, I'm expecting that there will be some conversation about this change. So in terms of looking at pain management, the main difference is that we are now recording, so along with were patients provided with pain relief within 30 minutes, were patients given a nerve block prior to surgery, and importantly, patients who have transferred from another hospital, were they given a nerve block prior to that transfer? You will note that the measurement of whether pain was assessed in the emergency department is no longer collected. Moving on to orthogeriatric model of care. So we have been collecting a number of these variables, but they now form part of the standard. So there have been two indicators added around frailty and delirium. So how many proportion of patients who've had a clinical frailty assessment using a validated tool, and whether patients were assessed for delirium after surgery. There's also the important introduction of nutritional supplementation. So how many patients are receiving protein and energy oral supplements during their admission? So again, this provides a couple of talking points. So one is that we currently collect information on the clinical frailty scale. So we have already identified which scale we've been using over the last couple of years. So we recognise that there may be sites either using or wanting to use another validated frailty tool. So at this point, what we've added in is an option to note if you're using another frailty tool. We will need to collect more information on this. Self-explanatory, the delirium assessment is now called post-operative delirium assessment because we also now have a pre-op delirium assessment. And then the question around oral nutritional supplements is really, did the patient receive these during their admission? yes or no? And Jack is here on the panel to be able to talk to this a little bit more too. So on to the timing of surgery. So we've really been keen to move towards the concept of patients having surgery either the day of their injury or the day after their injury. And this reduction in time does match with other international registries and the international evidence base. We appreciate that no hospital is managing to get all of their patients within 36 hours, and that some sites are closer to this than others. But we feel it's important, we will certainly support the Commission in making this change. We feel it is important to be able to have, to be aiming for this, and to really put a focus on how we might achieve this. We know, if you remember from the most recent report, and in fact reports over the last few years, that about a third of the delays to surgery are access to theatre. And we recognise that that requires changes at a system level to be able to change that. But there are some factors that we as clinicians can continue to look at. So particularly just under about a quarter of patients who have a delay to surgery because of medical reasons. And sometimes they are not necessarily a reason to delay surgery. And about the 14 or 15% who have delays due to anticoagulation. And we've been doing some work in terms of trying to reduce this as a reason for delay. So again, I imagine that there will be some questions or comments around this change. So mobilizing and weight bearing. So we have, will no longer be collecting where patients offered a chance to mobilize, so that we can focus on do patients actually walk. We're also no longer recording whether there was unrestricted weight bearing status. So the key point here is that really focusing on first day walking as being the key metric here. In terms of minimizing risk of another fracture, this is really just a change in wording for us. So rather than measuring whether bone protection medication was provided during the acute admission, really looking at whether it was provided during the hospital stay. And for those patients who don't receive it in hospital, we now have the opportunity to say, no, they didn't, but we did provide a prescription when they left hospital. We've also added in a couple of other options for bone protection, so raloxifene and hormone replacement therapy. And then on to the 7th quality statement, so transition from hospital care. Again, this is really reflecting on the some of the facility level audits being retired, and the follow-up data has been moved into another set of indicators. So we will continue to ask one question regarding facility level, and that will be via the dashboard. And that's really this important point of providing patients with individualized written information on discharge, which includes all of the secondary prevention, which is really key once somebody's recovered from their hip fracture. So thinking around future falls and fracture prevention. And on the screen there is on the left, the My Hip Fracture Care Guide, which is, or both of these are available on the website. This one has undergone an update, and on the right is our New Zealand document. So I think that that is me for the meantime. And actually, so this is really just an explanation of what's been happening in the last month to get us up and going for 2024. So all of these changes have required changes to the data dictionary and the patient level form. This creates quite a lot of work for Jamie because these all need to undergo an ethics and governance review. So that is well underway. And then that information will be circulated to all of the principal investigators and site coordinators so that everybody can hit the ground running at the beginning of the year. A reminder here that the patient information pamphlet does need to be given to patients who are being included in the registry. It's really important from an ethics and opt-off consent process. And all of these changes will be updated on the website shortly. And as Jackie said, those of you who are going to be involved on the ground collecting this information, Nicola is going to go through these forms in a bit more detail shortly.
Lovely, thanks very much, Sarah. So useful information there. If people have got questions, please do type them in. Otherwise, I'm going to hand over to Stuart. He's going to talk a little bit about the database functionality. Over to you, Stuart.
Thank you, Jackie. All right, I'm going to share a screen. So this is, I've logged in. This is the demo version of the Australian Hip Fracture Registry. I've logged in here. You'll see here as Dummy Hospital. So as Dummy Hospital, this is obviously not real data. When you log in, firstly, you'll see this particular dashboard. So it gives you a snapshot of the active patients, when a last record was modified, how many records for the current year. Sorry, we don't maintain the demo one, so it's 0, and how many records in total, which is just the 10. Then on the right-hand side here, we have patient type, so you can sort of drill into whether you want just inpatient falls or transferred ins only. At the moment, it's just all ticked, so it's all patients. And sorry, I'm just checking the Q&A. And this is the sort of the more interesting one. So from here, you can actually see this year. So there are no patients entered for this year. You can look at the last year, the last 30 days. You can actually type in a particular date. So from and to here. But if I say all records, this is what's showing up. So it's showing me all 10 records. Then we've got time-based variables here. And down the bottom, we've got quality standard variables. So just starting at the top there, time in ED, the number in the square bracket 6. So what that's showing is that 6 of the 10 records have a time in ED. For whatever reason, again, the dummy, it should be 10 of 10, you'd think. But if they were transferred in, then we wouldn't have captured their time in ED if they went straight to the ward. So what we've got here is your average, your median, the shortest record and the longest record. We find that one useful in that if this is a particularly long time, so there's a 300 here, then 300 would sort of indicate that you put a wrong year in. If it's the length of stay is 300 days, it's probably wrong. And these ones actually links to that particular record. So if I click on time to surgery, the shortest is 24, longest is 57.87. If I click on that one, that will take me to the record for Joseph Stalin. And we can look at the admission time and the treatment time and see, oh, okay, well, that's 57 hours. Well, that was correct for whatever reason. Dashboard there will just take you straight back to this dashboard. Let's go back to all records again. Down the bottom here, we have the quality standards. There are 7. These will change in the next calendar year, so that January 1st, these will be changing. But at the moment, we have a cognitive assessment prior to surgery. There are 9 of the 10. So in all instances, the bracketed number gives you how many of the total it found are included in this number. So next year, we won't have pain assessment within 30 minutes. We will have analgesia within 30 minutes and nerve block prior to transfer is being added. So we'll be 3 there. For QS3, the orthogeriatric model of care, assessed by geriatric medicine is out, and clinical frailty assessment, post-op delirium assessment, and oral nutrition supplements are all in. So there'll be 3 similar to this one here in QS3 for next year. Surgery now, up until recently, it was surgery within 48 hours. We're changing it to 36 hours, but we put it in now so you can see both, so you can see how that would affect your numbers. For QS5, we will be losing unrestricted weight bearing, but keeping pressure injuries. And QS6, first day walking is being added. Am I reading this right? No, sorry, QS6. Bone medication on discharge will stay, as will falls risk assessment, and this one is will be going as well. So we won't have a QS7 at this stage. This is really cool to be able to just dig around and see what's going on in your records. But this doesn't give you any indication of how that looks compared to other hospitals. So over here we've got the button reports. And again, I'm going to have to keep changing to all records because this is dummy data. So you can see there is a couple of records back here for all of Australia. So this is Australia versus Queensland. Dummy hospital, by the way, is a Queensland hospital. I've been there, it's awesome. So this shows you your how you compare with your state and the national average. And you can change this to look by months and change it by periods as well. And again, this here works. So if you wanted to change it and show till 2021 only, there you go. That's the 2021 and say 19 looks nice. Give you a better idea of what's going on. So in here, this allows you to switch between reports, and these reports mirror the national report that's produced every year, with the exception that surgery less than 36 hours are added recently, so you can see roughly how you compare against state and national averages for surgery. Please ignore the fact it goes from 0 to 100% because there's just so few records. And that's what it would look like at 48. So there's a lot of stuff in there that you can look at. While the indicators might disappear from the dashboard, they'll remain in the national report and the reports. And with these down the bottom here, for each report, it tells you exactly what's going on. So it tells you that for this particular report, the hospital count is 10, the state count is 67, national count is 103, and it's a percentage of patients with a hip fracture who did not acquire a pressure injury stage 2 or above during their stay. So each one of these reports has that sort of thing. So if you're not sure what you're looking at, here's the malnutrition report for the period. Should be the same numbers for the hospital, but different for state and national. Again, it'd be different because some of the records have that value and some don't. You can also hover over to get information on the percentages. Yeah, so there's an awful lot of data in there, but I'm going to keep moving because I know I've only got 10 minutes and I'm running a little bit behind already. Can mortality be added? So not here. So this is live data, and mortality is not live. Mortality we get at the end of the year when we submit our data and get it matched, and then the mortality data comes back. However, that being said, if we go back, and in fact, what I might do, let's see if can someone give me a thumbs up or let me know if you can actually see the ANZ Hip Fracture Registry, the live one?
Yeah.
Is that
Yep.
yes?
Yep. It's fine.
Yeah, perfect. So in here we have clinical reports. This is access that everybody has. So you notice I didn't log in, that everybody has to all of the reports that we generate for the national report. And this one has things like 120-day follow-ups and all the rest of the stuff. And you can actually look back year by year. You can also select your particular hospital and then find that hospital within that line. And if you hover over it, it'll give you some more information there. So there's a lot of stuff in there that allows you to see. These are the non-real-time reports. And then back here are the real-time reports. One thing that I did want to cover off and show off just before I finish up, and I'm going to log in here. Everybody, just close your eyes while I quickly log in. There we go. We're done. Down the bottom here, we have the export function. So if you're a hospital administrator, you can export records for a particular period. So this gives you all of the data that you've entered for whatever it happens to be. So whether it's the last 30 days, last year, but you can actually type in your own dates here. It will then tell you how many records it thinks it's going to export. I would recommend you leave this at whatever it's set, because it's not referring to the data, it's the data format. And so that includes all the columns and everything that you'd like. Identifiers by default is set to no. We recommend you use this with caution. If you're exporting all your data identifiers, you've got to treat it, with due care. We don't want it left on a bus on a USB stick somewhere. Include the EQ5D. By default, it's no, but if you are definitely capturing that and you want to analyze that, by all means. Custom fields. Now, we do have the ability for people to record custom fields, and that allows you to capture anything you want. That appears in its own tab at the end. So where you've got the 120-day follow-up, that would appear at the end. And this also includes the date of death. So as recorded for the National Death Index date. So all of these are options. So once you hit export, it will save it as a spreadsheet that then offer you to download that. And you can run your own reports on anything you like at that point. I think that's it for me. I will relinquish control back to Jackie.
Thanks very much, Stuart.
Jackie, could I just interrupt, because I just realized something I didn't mention in my talk, and Stuart hasn't, but it will be easier to identify whether there was a delay to surgery or not. So previously, so it will only come up if there's been a delay to surgery, and then you will answer what the delay was. So if the patient does happen to have got in within 36 hours, that next question won't be asked, just to make it a bit more streamlined, which Stuart's showing us.
So if that was, it's going to be something there. It's 9 hours, that one will disappear because you don't need to fill it in. It's less than 36.
I think
Cool.
we'll all be struggling with the 36. It's ambitious, but it's the right thing to do for patients. All right, so Q&A session. Can our panelists miraculously appear, please? So Sarah, of course, will be joining us. We've got Jack Bell, dietitian from Queensland, Nicola Ward from New Zealand, Chris Ward, Wall, an orthopedic surgeon from Queensland. Oh, we've got a lot of Queenslanders, actually. Jamie is also around if there are questions that are specific to Jamie as well. So type in your questions. I'm just going to go through them in the order that they have been provided. Some of you sent questions in advance of the meeting. So we put those in. JB's been posting those. It's not that we've made them up ourselves. All right, first question looks like it's for you, Jack. And you've had some time, I think, to look at this one. And I've been told that you've got a couple of slides as well. So the question is, what advice do you have on how sites can meet the nutrition aspects? Oh, I just lost questions when you did that. What advice do you have on how sites can meet the nutrition aspects of the standard given dietitian resources vary between hospitals? Jack.
Yeah, can you hear me?
Yep.
Great. Okay, and can you see my slide?
I can see 7 slides.
Yeah, and I'm going to do it in under 3 minutes, so I'll be really quick. So, but I know there's been a lot of questions across Australia and New Zealand, and particularly New Zealand around the supplement side of things, given way nutrition's done over there as well. So I'll be quick. You can read what the indicators are in the new clinical standards, but it's not just about supplements, even though that's what we're measuring. So it is firstly about the full nutrition care process, including identification of malnutrition and then, you know, right through to interventions, and making those interventions should include making sure the patient is aware of their nutrition status and any interventions provided. The other thing I'll just note is it is pretty hospital centric, but that's what this actual audit data set is about. But good nutrition care is definitely not nutrition centric. So the main indicator that we're measuring in the new standards has already been spoken about, so I won't speak to that. I also, in terms of the definition, it's worth noting the finer details of the definition, and I'll see if I can do this. Yes, I will zoom in here. So documented patient level evidence must be observed as evidence of receiving oral nutrition supplements. Now, please, and given a lot of people on here will be collecting this data, it's worth noting that if that's buried somewhere in your food service system, that's going to be very hard to collect. So I would suggest that sites set up some kind of processes whereby if you are giving supplements, that they are easily being able to be identified as being given. And to me, the easiest way of doing that is if they're prescribed on the medical record, and that has advantages as well, I believe. But I'm not going to tell you guys what to do, but just think about implementation and what's the easiest way to get it to everybody, and then what's the easiest way for auditors to pick that up. And if you want to talk to me about that later, I'll be very happy to talk to that. The only other thing worth noting just at this point is in the original definition of nutrition assessment or a clinical nutrition diagnosis, please note that this is for not just a nutrition screen, but an actual documented nutrition assessment. So again, if you've got any queries about that, there's a number of different diagnostic tools that are used, but please check with your local dietitians to make sure it's not a screening tool. But the question is really, how do we deliver like nutrition care, especially if there's limited resources, for example, dietitians? And we've written a book chapter about it in the orthogeriatrics textbook. I've provided the link there. And the reason I've used these slides, Jackie, is just so that people can see these links and go to the resources. In there, we talk about simple nutrition care, which is systematized and interdisciplinary processes. And there's lots of different ways that care can be delivered that can be orchestrated or managed by a dietitian if you have one, but don't rely on the dietitian to deliver that care. Because we know that most people with hip fracture don't need a specialist dietitian to come along and deliver care. They just need good nutrition care that's delivered by systems and members of the interdisciplinary team. I'm not going to talk to what those could look like because they're all documented very clearly in that chapter. They're also very well documented in a new fragility fracture resource. There's 3 of them. It's called Interface. And again, there's a QR code there if people want to look at that later. There's a frailty and sarcopenia module that Finbar Martin's written, which I've also helped Finbar with. And then we've got a nutrition module and a rehabilitation module as well. So that will answer a number of questions people might have in this area. And then second last, we've got the ANZ sprint audit from nutrition care. And I don't expect you to read all of that finer detail, but that's a taster just to say, if you go to the ANZHFR website and look up sprint audits and then look for the nutrition sprint, we've actually listed out really clearly what are the evidence-based recommendations for systematized and interdisciplinary care processes that will help sites to meet the standards, even when there are limited resources. Finally, We do have a big MRFF grant in where we're trying to do an implementation hybrid effectiveness model to help all of you guys to do improvements in this space. We're not sure if we're going to get it, but if we're not going to get it, my final point is we'll probably just do it anyway, just with less resources. So that's me. I'm done.
Thanks, Jack.
I'll just work
All
out
right.
how I can stop share.
Next question, someone's trying to seek clarity around indicator 3A, and it's the issue of using a frailty tool for measuring. So our district would like sites to use the frail scale as a tool of choice. Can this be used and counted in this data definition? I think that, Sarah, do you want to answer that? Or yeah.
Yep. So when the registries decided to think about measuring frailty, we canvassed all of the sites as to what tools they were using, and most sites were using the clinical frailty scale, which is why this was picked. So that's been recorded for the last couple of years, and does provide us to be able to sort of break out between non-frail, pre-frail, and frail, and more severely frail. So at this point, all we're able to decided to do is to have a box if you are using another frailty tool. You won't then be able to put in your results, but you will be able to indicate that you are using a different tool. And we will be able to see whether there is an appetite for using different tools. Although both those tools do measure frailty, they do it in a slightly different way. So the frail scale is a self-reported measure. The clinical frailty scale is a sort of clinician judgment. So I think we would need to think more carefully if we wanted to bring in either a different, add in a different scale or tool, or have a variety of tools. Don't know, Jackie, if you've got any other comments about that.
No, I mean, the registry has intentionally tried to avoid being prescriptive, but the CFS is by far the most commonly used tool for measuring clinical frailty, and it's a useful one in terms of risk adjustment as well. But we can't force people to do it. So we've left the facility to be able to document that you have used some form of frailty scale. We just won't be able to look at the results. All right, one for you, Chris. I've never heard of this. Is the femoral neck system being used in many places as a surgical option? Should it be included in the data dictionary as an example of a sliding hip screw, along with a dynamic hip screw?
Yeah, so good morning, everyone, and thanks for the question. So for the non-surgeons in the audience, the femoral neck system it's a proprietary device used for internal fixation of subcapital neck of femur fractures. In answer to the first question, I don't know how widely it is used, but in answer to the second question, the device behaves very similarly to a sliding hip screw, and that allows controlled compression across the fracture site, which provides a biomechanically favourable environment for healing. So I think it would be reasonable to code as a sliding hip screw.
Lovely, thanks for that, Chris. First day mobility. The data dictionary is quite clear that the patient must take at least one step on day one. Therefore, if you transfer somebody out of bed using a SARA steady, even if they sit out of bed or use a commode, it does not count as mobilization as they haven't taken a step. Is this correct? I think the short answer to that is yes.
And I make a couple of other comments, Jackie. I mean, I think the SARA steady is a great transfer aid, and certainly we'd rather, patients are better to be out of bed than in bed. But from a mobility walking point of view, we really do want people, staff working with patients to try and stand and take a step, rather than being able to sort of more quickly move them from bed to chair. I do think I'm aware that it's become an increasing practice using the SARA steady, but I think we should still be focusing on trying to get patients weight bearing, taking a step.
Thanks, Sarah. And certainly all the literature is, in fact, in recent years, the literature is increasingly providing evidence as to how important early mobilization is in terms of outcomes for patients. All right, the next question is not a question, it's a statement. Bone protection medication discharge. I'm going to skip over that one, and whoever's put it in, if they could put it in a question format, that would be helpful, because I don't really know how to answer that one.
It's linked to this next question below.
New patient level form doesn't include patients deceased. I'm not, Jamie, are you able to help me there?
I am. I believe we had an inquiry about this. So in WA, I think they were collecting information on people who didn't receive bone protection medication for people who were either died in hospital or were on a palliative care pathway. It wasn't ever part of the national data set. And I think we have discussed it many times as a registry, but there's no expectation that bone medication on discharge would be 100%, which is why we've never included an option around people being palliative or deceased or other reasons why it might not be appropriate. But I think the answer to the question is that our form doesn't include it because it never did, and it's a WA specific field that's captured as a custom field in West Australia.
Lovely, thanks for that, Jamie. Anita, apologies, I joined late. Will the 2024 registry template be available to health units before the end of the year so we can set up? The answer to that's a nice simple yes.
I think also Stuart, because Royal Adelaide exports data, Stuart might have to comment on the availability of the export template, which might be, it's the Excel template that the importing hospitals use and when that might be available.
Planning to have that available in the next 2 weeks, so it'll be probably a week before it goes live, but that's as soon as I've got it, those that are importing will get a copy of that.
Your Christmas present to me, Anita, would be to just enter the data directly into the registry rather than import, but I'll leave that to you. All right, delay to surgery. Over the past couple of years, there's been an increase in delay of patients transferring into the operating hospital. Do not know the reason for the delay. Delay of transport availability or delay in initial booking. Okay, and bed block. I don't think that's something we've tracked. Chris, though, I think wants to comment on that. Chris.
Yeah, look, I was just going to comment anecdotally. So I work in regional Queensland and almost 50% of our patients are transferred in, which is a significant challenge for us. Anecdotally, delays are multifactorial. So there is local bed block issues, but there's also issues with getting patients from the peripheral sites. So in Queensland, if you're greater than 2 hours transferring, you're transferred via air, and that is dependent on weather and asset availability. And if you're less than 2 hours, you're travelled via road. And at night, there are, animals on regional roads. So you've got to weigh up safety versus time to transfer. I think this is an important discussion for all of us to be having with our local key stakeholders. So we're meeting with RFDS and QAS, the Queensland Ambulance Services, about this. And there's going to be, local solutions, I think, for each of us to come up with.
Thanks. That's a really good question. And it's not something we'd really picked up in the registry. So asking those sorts of questions means we will look at it for next year's report and to see if there are trends for times to transfer getting longer, because it is something then we would definitely want to highlight. I think Hannah Seymour on multiple occasions has recommended that people who work in hospitals where a large proportion of patients are transferred, you should have transfer protocols in place. And if you don't, I think Toowoomba does, doesn't it, Chris?
Yes, we do. Yeah.
Yeah.
And that has facilitated meeting a lot of the indicators, but it is still a challenge for getting the time to surgery.
And again, if people are interested in those protocols, so I'm pretty certain WA has a protocol, Toowoomba has a protocol, because we listened to that at HIPFest a couple of years ago. We are really keen to share resources. So if you want some of those resources, please just reach out to us. Happy to share. Sunita, will 1 year mortality be reported eventually? Yes, not in the live data because of the problems of the time it takes for us to get the linkage with the National Death Index, but ultimately, yes, it's an important outcome, and certainly when people apply to use the data for research purposes, they will also have access to date of death as well. So that information is potentially available. We didn't report mortality this year with problems with the linkage, that we will be reporting mortality early next year before the next year's report. All right, would it be possible to have a question around polypharmacy and also the drug burden index for anticholinergic effects, as these are significant contributing factors to falls? So it's not something that's built into the registry at this point in time, but it's a perfect example of something where you could introduce a custom field. So if at your hospital you wanted to collect information on the drug burden index, it is really easy to set up a custom field in order to be able to do that. And I think probably not enough people are using those custom fields. Lots of sites have got their own research questions they might want to ask. We've certainly done some work trying to understand what the barriers are to first day mobilisation, but you can certainly do that. There's no plans at this point in time, though, for that to be included in the national data set. We are really loath to increase the burden of data collection, but that does not mean to say we wouldn't do it in the future. Does anybody else want to comment? No? All right, is a high nourishing diet ordered on admission suitable to tick yes for this? This is a question to you, Jack, or do we need to consult review in day 1 to 3? Or I hope everybody's not referring to dietitians just to prescribe nutritional supplementation with all due respect.
Okay, Jackie, I was going to ask you a question, and I was going to ask you, who should prescribe oral nutrition supplements? Does it need to be the dietitian? And you've just answered that question, so that's good. Yeah, so can everybody please hear that? And I know there are implications for that in some hospitals, because hospitals have got established processes whereby they can only be prescribed by a dietitian, which is why it's now written in the standard, because that practice will have to change. Dietitians cannot get to patients fast enough to put them on oral nutrition supplements. It should be a role of the admitting doctor. We've been doing that at Prince Charles since 2014. And to the point where now when they're in ED, as well as ordering a CT, the ED doctor will often write in start TDS resource 2.0. Depending on the tender, that might change, of course. Now, back to the question though. So a high protein diet isn't actually one of the measured variables within the new standard, but it is definitely an important component of care. And like I said earlier, it's not about just supplements. And so food first approach is very important. I strongly believe that placing all hip fracture patients on a high protein, high energy, nutrient dense and high quality diet is about the best possible thing we can do for this patient group. You know, room service models of care, for example, we've shown that they almost double protein and energy intakes when you put people onto room service. So if you can get your food service systems right for these patients, I defy any individual dietitian to produce such a good outcome, or a geriatrician or anybody, by just doing one thing. So it's about, again, the dietitians clearly should be actively engaged in this food first approach, but that doesn't mean they need to prescribe it. And again, if there's local processes that mean people can't go on a high protein diet until they've seen a dietitian, that needs to be reversed for people who have a hip fracture, basically. And so there needs to be established processes that these patients are at extreme risk of malnutrition if they're not already malnourished. And why wait until you absolutely know they're malnourished when we already know they're not going to eat enough in the first 1 to 2 weeks after discharge? So please, if you've got any sites that are unwilling to engage in this because of a cost factor, contact me. I will give you all the resources, all the evidence, all of the information that will help convince your local administrators and or dietetics departments that this needs to change. Sorry, I was pretty firm there, but I think that's important.
Yeah, thanks, Jack. Yeah, I very definitely prescribe to everyone, and I don't believe I've ever overnourished anybody. Seems unlikely. Some people don't like it.
Jackie, can you just add a comment too about people with, you know, stage 3 kidney insufficiency or anything else like that? Do you actively worry about protein for people whose kidneys aren't so good? Because often I am yet to find a geriatrician who starves my patients because they're worried about their renal function. Could you make a comment about that? Thanks.
It would be rare if somebody had severe kidney disease, but we've access to things like Nepro, which are designed for renal patients. But in the first couple of days, these patients are highly catabolic. They're breaking down protein rapidly. I've never done any harm giving them a high energy, high protein diet for the first few days. And then I just engage with the dietitian about a conversation about what's appropriate for that person. But they're the exception to the rule. We should be planning for the masses, not the exceptions. All right. Who's responsible to complete the frailty tool? OTs or author-cherries? Okay. If you're doing
So I answer that, Jackie. I mean,
yeah.
It doesn't matter. So, you don't need to be a specialist to be able to do the clinical frailty scale. That's one of the beauties of the tool. Every team will have a different system set up. I mean, where I work, it's the ortho geriatric registrar generally who does it, but that it could be any member of the team at any point along the pathway, to be honest. Ideally, emergency department, that would be great, but probably not often done.
I mean, the questions are pretty simple. And in fact, if you're doing a decent social history and you're working out whether patients are able to undertake their own activities, daily living and personal activities, you've got your CFS score and you've done your proper social history. But it's whoever wants to do it. Jamie, got your hand up?
I was just going to say that Hannah Seymour did a video on completing the CFS last year, and I will share the links to some of the resources Jack's mentioned and to the video as well when we send out the recording link to everybody.
And in fact, that video is an orthopedic surgeon doing the clinical frailty scale. So anybody can do it. You just have to work out what works for your I didn't mean it quite like that, Chris. You just have to work out what works for your individual hospital. All right, Rami, in our hospital, most of our NOF patients are on a high energy, high protein diet. I think we're going back to the thing. But for high energy, high protein supplements, does the dietitian need to see the patient first? I think you just have to negotiate. We had to negotiate with the dietitians to say, look, we're just going to prescribe the high energy, high protein drinks, but we still plan to have discussions with you if we need anything else done. Jack?
So I guess my comment is, and Jackie mentioned it briefly earlier, the dietitians just can't meet the volume of care that's required to deliver them in a timely manner. And by actually systematizing it, the dietitians are then freed up to see those people who actually are complex and need specialist care. So as long as it's approached the right way, it's a win-win for everybody, especially the patients. So again, if anybody has any queries or is finding it difficult, please don't hesitate to contact me, and I'd be more than happy to facilitate some engagement amongst your teams to change practice.
Thanks, Jack. Nalini, is arginate supplement required when patients are already on a high protein diet? Jack, you got your hand up, or has it not come down? Or do you want to answer that? Or
sorry, I was so busy trying to get my hand down that I missed the question. What was it?
Nalini's asking about arginate. I only ever use arginate for wound healing when people's CRP is less than 35.
Yeah, look, I don't think the evidence stacks up adequately to be using these kind of processes ubiquitously. In the end, it's about protein and calories, and we know these patients don't get enough. But I also, my stance is usually, especially when it comes to supplements, I don't chop and change to flavor. It's actually a medication. And if you treat it as a medication, and if the patients aren't drinking it, it's probably they don't understand the importance of it. So rather than changing from chocolate to strawberry, I just get my geriatrician to go along and have a chat with the patient. Because if people drink Resonium, I'm reasonably confident that they can actually drink a supplement as well. They just need to know that it's important.
All right, well, Donna's back again. Dietitian review for positive MST score only, or all hip fractures? The system can't cope with a dietitian being asked to see every single hip fracture. That's just not feasible. I think Jack's reiterated that a number of times. The base, what we're trying to aim for, is a base where everybody is offered high energy, high protein supplements. And then if you've got people you're worried about that are malnourished or whatever, absolutely involve your dietitian and you get a much more refined assessment. And also, probably more important, and something we haven't really looked at yet, is planning for nutrition after discharge from hospital. We're way behind the 8 ball this country. I think Iceland's way ahead. Jack, would you want to comment on that?
Yeah, look, we're in the middle of rolling out a study here in Queensland to look at this, and yes, Iceland is way ahead of the game in terms of their home foods. Don't get me started on this topic. I know in our hospital, we do great care for inpatients, and ask me about our post-discharge nutrition care for any of our patients. I can't tell you think it's so this is an area we are actively working on. Just back to the nutrition assessment statement, there is a measure that we do capture in the registry still, that is around a documented nutrition assessment. But again, that doesn't need to be a dietitian, and dietitians can train, like nutrition assessment can be part of a comprehensive geriatric assessment, and actually should be. So we can actually train our registrars and consultants to get that diagnosis in there. I do think it's important, if we are giving people therapy, they need to know what that therapy is for. And especially, as Jackie said, post-discharge, if people don't know they're malnourished, then we can't improve it. And so we do need to, somewhere along the course of their admission, identify those who are malnourished or remaining at risk of malnutrition, but especially those who are malnourished, and make sure then that that's documented in their discharge plan moving forward, so that the ongoing care provider can be engaged and do something about it. So it is resource intensive. But a study that we've just done across nearly 50 countries globally has shown that only half the amount of hospitals, well, let's just say patients to make it easier, who are receiving supplements are actually being given any information about nutrition. And then we've got countries wondering why supplements aren't being drunk very well. It's because people don't even know they have a problem and what the drinks are for. So we do need to make sure we get the education component right and the diagnostic component right as well.
Thanks, Jack, and thanks, Donna, for all those questions. It's been good to highlight nutrition. So this is a new standard for us, and as Jack says, we've got a long way to go in terms of optimizing nutrition in hospitals and beyond. So it's been really good having that conversation. Nalini, would provision of simple analgesia such as Panadol be considered as analgesia within 30 minutes? Yeah, absolutely. Yeah. No issues there. Works. But yes, if you're given it within 30 minutes, that's absolutely fine. All right, there are no more questions at the moment, and we are on the dot of 1 p.m. So I'm going to hand over to Nicola, and she's going to talk about the practicalities of the new form for those entering data. So over to you, Nicola.
Everybody back there. Hello everyone, I'm Nicola Ward. I am currently sat in Papamoa, New Zealand. I am the registry coordinator for New Zealand, so I do Jamie's job over here. I think it's good afternoon everywhere for everybody. We're just going to look at the form. So as well as being the registry coordinator, I'm also an FLS nurse at the Bay of Plenty hospitals. We have 2 hospitals in this region. So I do go up onto the orthopedic ward. I see the fractured off patients, and we collect the data. We use a paper form, and then we send it back to our admin staff to upload into the registry. So on the floor, I carry this data form around, which I'm going to share with you, and I'm just going to show you the changes within it. So we haven't done changes for a couple of years, just the odd little one. But this one has changed significantly. So I'm showing you the New Zealand one. The only difference between the New Zealand and the Australian form is the demographic part at the top here. You can, and it's to do where the ethnicity is, and we call ours a National Health Index number, and yours is called the MRI or MIU. And also added into this, for the coming 2024 year, Australia will have an individual health identifier. And that's to do with future proofing for the registry for exchange and research and data. So when you look at it, it will look slightly different for 2024. I'll go up and I'm just going to look at the changes. So probably most of us who collect the data can go up in the ward, whether you're doing it on your iPad direct into the registry or on a paper form. And I could probably go with my eyes shut and tick which boxes that I want to do. And I'm probably going to grumble for the first 6 weeks of 2024 as I try and get changes on this form. So Jamie, who changed this, is keeping everything as best she can, but as you've just heard from the last hour, we've got quite a few care standards that have changed, so we have to add them in, but also some have retired. So you will see down here, transferred patients only, and that's about nerve block transfer. And I hope to goodness that everybody is ticking yes, because being with a fractured hip in a ambulance or even flights, as what Chris was just talking about, around Queensland can be very unpleasant. So I hope all our transferred patients are getting a nerve block. And then we'll come down. Now, this is the bit that's going to confuddle me a little bit. So I hope you put some questions in the chat about this. So Sarah talked about this. So we're now asking pre-admission cognition, which was there before. We're asking a pre-operative cognitive assessment, and you can use a 4AT as it says, but we're also asking about delirium. So this is about, is their brain functioning properly, and was there anything that they noticed? And then this is there a delirium pre-op, so prior to surgery? So we do a 4AT, so I'm going to have to sit with my orthogeriatrician and work out how we complete this correctly. So that's the little bit that's probably going to confuse me the most, even though I've done it this for a few years. So please come back to myself or Jamie with any questions that we've got, because we can talk about them and do further Q&A if need be. As a fracture liaison nurse, I'm very happy that we're adding more drugs in here. So that's just the change there. And what we've also talked about from questions, not everybody's using the clinical frailty scale. So if you're using another tool, that's just added in there. So pretty simple on that first page, just remembering about your transferred patients and the delirium assessment. And then we'll come down. And then there's now the dreaded less than 36 hours to surgery. And then you only click, you're now only saying a reason why beforehand. What I didn't realize, and thank you, Stuart, because I've learned two things from the dashboard today, even though I look at it regularly. I am going to take what I can see already from my 2023 data that's got 48 hours and 36 hours, and I'm going to take that to my principal investigator, because it shows you a change already from this year's data, even though not recorded at less than 36. So I'm going to take that and use that. So that could be a tool to get the conversation started with the people that matter before we start recording it officially next year. I'm going to drop down here. Okay, we've just changed the wording here to pre-operative delirium assessment. So one prior and one post is what we've had. And you'll notice that we've taken out a lot of, we've taken out the opportunity to walk, where we've talked about how important it is that everybody walks. So if you look at the New Zealand data for last year, my hospital was the worst in the country. So we are doing a project on that through our custom fields. What is the reason that we're saying no? And well, the main reason we're finding is people are just going straight to the steady Sarah. So it says Sarah steady. So we're doing a custom field on that. And if I don't talk long enough, maybe Stuart could share what it looks like to do a custom field on the registry. So as you can see, not too much change, just a little shift round, but just to remember these are changing. We've talked about this. Jack has let us know what we're looking for about the oral nutritional supplements. Is a yes or a no. It's so vast across, particularly New Zealand. I think I struggle with this one up here. Who does this and who gets it done? And we're very often not done, but I think everybody gets this. So I don't feel so bad about this one if actually I'm documenting that something's being done. Now, as a fracture liaison nurse, this makes me happy because it makes our data look a bit better. So we've added in here, they may not have been treated in hospital, and predominantly in hospital in New Zealand, it would be the IV zolendronate, or your cluster infusion, and then maybe the injection more, the denosumab in Australia, and the bisphosphonate IV. But, you know, you can give a script for your Fosamax or your denosumab, so then we can tick that we've done that. Not a lot of change on this 1 to 3rd page. If you're looking at it in paper form, that seems very similar. We've just added in here the extra stuff. And I'm just going to go down. I'll be interested in, so the word optional used to be here for your 5QD questions. I wasn't doing it because it was optional. Now we will start doing it. So yeah, so we would love some data around this, learning about your patients and how they're doing. This is a 120-day follow-up. So I'll just give that a little plug. I always find these questions quite hard for the patients. They want to score 99, and they ask you for their opinion. So this is, if you want to look at that, it's all explained in the data dictionary. And I think that's possibly me for everything. So like I say, it'll take probably 6 weeks of me grumbling as I go and do this in January and February to notice all the changes that are happening, particularly on page 1, that things have moved across. And I just think, you know, it would be good to go and take this to your multidisciplinary team, talk to the dietitians, talk with your orthogeriatricians, talk with your head of orthopedics about how this is going to look. Because 2024 is slightly different for us from the registry, just aligned with the clinical standards. And I think, oh, I've got questions. Do I need to look at them, Jamie? I'll stop sharing.
I can take you through them, Nicola. That's really helpful.
Thank you.
It's a question: where would the IHI be found? I'm missing it. The IHI to me is the Institute of Healthcare Improvement in Boston.
It's the individual health identifier. I don't know where. I think the healthcare improvement, is that in Boston or somewhere overseas?
Yes,
but this one won't be that far away, but good luck to people finding it. So I'll just make a comment on this. So this is a number that we've been asked, all registries are being asked to include as part of their data set, really for the future when it will be hopefully more easily found. For people that don't know what it is, it's a unique number that identifies individuals for healthcare purposes. Anybody in Australia has an IHI if you have a Medicare card, have a DVA card, or are enrolled in Medicare. So I actually found mine by going on to Services New South Wales, and I didn't know I had one. It's a 16-digit number, and the start of it would be the same for everyone. So it'll start with 800360. Whether it will be in your hospital's health record as yet, I do not know. So it's optional. If it happens to be on your hospital front sheet or a system that you use to collect other data for the patient, it would be great if you can pop it in. If it remains blank for the vast majority of people this year, that's fine. It's really, I think, for the future when the plans are for it to be more common, more commonly and used to identify people across Australia rather than have every hospital using a different system for medical record numbers, etc.
Yeah, thanks, Jamie. That's part of our endeavour to future-proof registry. You may not have that data. I mean, ultimately, it'll come on your sticky labels that you have for patients, but it's not happening yet. All right, Sarah, would it be possible for one of the panel to comment on the 480 and the advantages of using it?
Yeah, so I quite like using the 480. Certainly, well, becoming better embedded into the hospital I work across a number of services. I think for our purpose, it's quite a good one to use because it can detect possible cognitive impairment and delirium. So for a pre-op assessment, if you do a 480, then you can cover off the preoperative cognitive assessment and provide an answer to that, and you can cover off whether the patient has delirium or not. It will require people to document what the score is so that you can distinguish between cognitive impairment and delirium. But I think that is a good way to go.
Thanks, Sarah. Can someone comment on the specialist falls assessment and what's included in this? Who usually would do it? Nicola, do you want to comment?
So a few years ago when this was introduced, again, our hospital was at the very bottom. So took it on a project and basically look at your data dictionary, and like your data dictionary is like your best friend linked to the form. So the data dictionary, I sat around a table with the geriatricians and the physios, and the geriatrician said, I do that. I write about, I want to stop that, whatever drug it is that's making them fall, or I'm worried about this. And then, you know, the physio said, we do that every time we get them out of bed, and we talk about the falls and we give them the booklet when they go home. So we covered we were doing it, but I didn't realize. I thought it was something deeper than it was. So we just used the data dictionary as a solid guide. So just to give an example, so it's normally, I think it says in the data dictionary, a geriatrician and a physio. Is that what it says? I think from memory. So you're kind of looking at medications. Does anything need to be stopped to reduce the falls risk? And then it's the physio, offering, and the OT as well, like offering some kind of falls intervention, some support, some knowledge, that kind of thing. So that's how we got, we found that we were actually doing it, but weren't recording it correctly. Jack.
I'll just put a plug in here, and I'm not saying we're going to change the data dictionary, but we finally published something that shows that malnutrition is associated with harmful falls. So as part of a good falls risk assessment, don't change the data dictionary, but as clinicians also think about whether your patient's got enough muscle to actually balance themselves okay, and probably got enough vitamin D so that they don't lose their balance.
Point taken, Jack. Nice one. Sunita, is everyone presenting their data yearly to the ortho teams? How is everyone ensuring their engagement? I can ask each of the panel members. I can assure you we certainly do at Prince of Wales. It's integral to what we do, and I also teach the orthopaedic registrars twice a year, and we go through the hip fracture registry. Every one of them can do a 4AT and the clinical frailty scale, and the data in terms of our performance goes back to the whole department once a year. Nicola, what do you do?
I attend their monthly acute orthopaedic meeting and have a byline of NOF every meeting, and just feedback any trends that I'm seeing and things like that, so they're aware that way.
Sarah?
Yes, I arrange a meeting once a year, which probably isn't enough, but at least it's doing that to be able to go through the current data. I haven't done it yet this year, but I plan to before the end of the year. And then I think the focus for me then will be on looking at the year ahead rather than the year that we've done. So it's really important. And I guess there are different things will need to be done to engage the surgeons depending on your local area. Some will be very engaged in asking you for the information. Others will need to, you'll need to take a bit more work to give it to them. But once you start, sitting around talking about the same patients that you're both looking after, then I think you can get some traction.
Chris, do you want to comment in terms of the talk you did to the AOA as well as whatever you do at Toowoomba?
Yeah, so locally we have an annual sort of journal club meeting where we would discuss the findings of the annual report, both the annual report of the joint replacement registry and also the hip fracture registry. It's always very well received and stimulates a lot of discussion. Yeah, I did present a very brief summary at the AOA annual scientific meeting last month as well.
So Stuart's developed these awesome dashboards that if you aren't uploading your data later can be pretty close to live. They're not live, but I'd also encourage sites that we do have these dashboards there, and especially as we've got some new care standards that are being built into what we're measuring, don't leave it till the end of year report to realize that it wasn't done particularly well. So make use of those dashboards where you can. I'm happy for somebody to correct me if I'm out of line for saying this, but maybe Stuart, this is an opportunity for you to comment, or somebody else as well.
Jack, I snip to them every quarter and send them out and say this is
the whole purpose of the registry is to use the data to drive quality improvement activity. If you're waiting for the report to land on your desk, you're missing the point. It is good to have an annual update, don't get me wrong, but people need to be constantly looking at the data to see where they need to change practice, or if they are implementing changes in practice, is that change effective? So it's constant quality improvement activity. That's the whole point of clinical quality registry. But it is heartening to hear how many sites are actually using the registry and providing feedback. And it's not just to orthopedic surgeons, it's to all disciplines involved in hip fracture care. That's very different to what it was 10 years ago. So that's fantastic. Any other questions coming in? Otherwise, we've got a few more minutes. I might ask Stuart if he's happy, just to give us an example or just to show us how to use the custom fields and maybe do it in relation to reason for not mobilizing day one. We'll give you some options. Is that all right?
Very happy to, as long as you're happy to help drive that.
Yeah, that's fine. Yeah.
Sorry, Stuart, I dropped you in
But-
it.
For those that are no, that's fine. But for those that haven't met me, I'm IT only. I can't spell medical, so as long as I'm being guided, I'm good. All right, so I'm going to share the screen that I had up before. I've logged in as an admin for the demo hospital. I'm hoping I'm going to click the right screen here. So we've got custom fields down here. One of the things I didn't mention just briefly, this is where, this particular hospital has a sprint audit still outstanding. This is the question, these are the questions for the hospital itself. And then inside a particular patient, you would see preoperative fasting again, and these are the questions that relate to individual patients. So if you ever see these pop up, this is because you're involved in a sprint audit. They will appear for a short period of time, and then they will disappear. When I say they will disappear, if you've entered them for a patient, for say you've entered it for Joseph Stalin here, that data will always be there. As long as you've put something in here, these fields would always show, even if the preoperative fasting survey has closed. All right. Down on the left-hand side here, we have a number of things. Firstly, transfer hospitals. I'm just going to quickly mention it. If you have a hospital that transfers to you and it's not in the list, you can edit yourself. If you click on transfer hospitals, that allows you to add a particular hospital in, and realistically, all you need is the name. You can put lots of other stuff in there, but that's just for your benefit. Once you have that, that then feeds back into the records itself. And so if I said it was a transfer from another hospital, those are the two hospitals that I have. And if you add a third, that's where that would show up. I mention that only because it is a question I get from time to time. Let's go down to custom fields now. So here is a series of custom fields that we've created. Down on the bottom here, there's tutorials on how to use it, both on Vimeo and on YouTube. First fractured date, so you can have dates, you can have drop downs, you can have a numeric with a minimum and maximum number. It can be as opposed to date and time. And then obviously for full just text, I just want you to give me your favorite child's name. Of course, nobody has favorites, so obviously it would be left blank or all. And mobilization barrier. If we create one, so let's just follow the bouncing ball. Those are the ones that we have. If they're marked as active, they will show up. If you mark them as inactive, they disappear from the form. So here we have hair color, purple, graffiti, bad wig, bald, brunette, and red. You can see I've been playing with this from time to time, showing people stuff. Language spoken at home, first meal in hospital, favorite child's name. And here it's got nickname is fine. Mobilization barrier, why they're not mobilized, and no idea, unicorn attack, leg fell off, just too stubborn. So lots of different options you can put there for yourself. If you get stuck on this, just email admin@hipfracture.com.au. That comes directly to me and we can walk you through it. As I said, there's a tutorial on it there, but let's just start with the display label. What did you say we were going to do, Jackie?
Early mobilization.
All right, and this is going to be a drop down. So we're going to have some set choices. We are going to display it. We do want it available for export and test for Q&A. So what happens now is we'll just save that. And there it is, early mobilization is already turned on. And now we'll go back and start adding some options. If you click on add option anyway, it will save it and continue. I'm just doing it, following the bouncing ball on this. What's your first option there, Jackie?
I'll just make them up. I'm too busy.
Right. Now this allows you, if you wanted to, this allows you to have a value for it if you want. So for example, if you want to say, well, too busy is 0 and then 1s and 2s and 3s, and you wanted to have that, you can do it that way, or you can just have too busy. And I always wanted to show as too busy because I can't remember what the numbers I set were. And there it is. We'll add a couple more.
Can I give you touch weight there, Stuart?
Touch weight. Ugh. As always, when someone else is watching you type, you can't do it. All right, we'll do that. And add one more.
On the phone. No idea, yeah, okay.
Perfect. So we'll save that now. So herbal immobilization is active. It's active for export. You can edit it either there or there. But now if I go into all patients and this is the demo database and I haven't played too much. Early mobilization is there. Too busy. Touch weight bear. No idea. My hover over is text for test. See, text for Q&A. Once you save that, it saves with the record the same as everything else. And then when you go to export, you can choose to export the custom fields, and it literally just lists them 1, then 2, then 3, then 4, then 5. These aren't used for reporting. They're not used in any national reporting. No one other than your hospital gets access to them. But they're there for you to use to capture what you want to capture, then export and analyze that as you see fit.
Lovely. Thanks, Stuart. That's really helpful. And I think it is an underutilized resource that we have. So please feel free to use it if you're undertaking quality improvement activity that's somehow related to hip fracture but not routinely collected. All right, a few more questions coming in. If patient was scheduled for surgery within 36 hours and delayed, which lead to several other reasons for delay, making surgery delay over therapy? Which reason do you delay? Oh, that's such a hard one, Nalini. I tend to tick the one that I think is the main contributor, but we don't allow multiple ticks at this point in time. We're happy to take feedback though over the course of the next year when we're looking at 36 hours. If it becomes apparent that it's more than one each time and that we're not adequately capturing what the delay is due to, then we can rethink that. But at the moment, it's just tick the one that you think is the biggest contributor to the delay, and the data all tells us it's predominantly access to theatres for the surgeons. Stuart, where did you get the ancestral painting from?
It's great-great-great-great-grandfather, and believe there is a great-great-grandmother hanging in a museum in Scotland. It is actually a blood relative, but we're unsure of his name. Dad has done lots of research and can't find it, but it is actually a blood relative.
Monica, I think the data dictionary recommends reason for first delay to be recorded. Although Monica's clearly read it than me. Thanks for that, Monica. Sanita can see the resemblance there. Stuart, yep, I can too. Anything else we need to cover? Always feel free to contact us if you think of other questions. But if there are no other questions at the moment, I guess this is our time as a registry just to thank all of you for your continued support of the registry. I remember what it was like when we started up and how the registry is now, and we've all come on a journey, that I'm pretty confident that hip fracture care is much better in Australia and New Zealand as a result of what you guys are all doing. So please keep it up, and thank you again for your ongoing support. Oh,